I am so delighted to meet you in the 15th session of JIP Academy Diabetes. In the last session, we saw about the glycemic control of this patient and how we were supposed to bring down the blood pressure. So, this session comprises of fully focus on how we are going to bring down or how we are going to set right the lipid abnormalities, and we are going to focus on the liver as well. So, if you look at the lipid profile in this patient, total cholesterol is on the higher side. So, instead of 180 it is somewhere around 329, and the value of triglyceride is, I think that it is very huge, 1289, and LDL is 69 milligram per DL, and VLDL you are all aware that it is 1/5 of triglyceride value. So, it is a very calculated value, it is not the measured value, and HDL is very low, it is only around 21 milligram per DL. When you look at triglyceride value, if it is more than 200, what you have to remember that the probable calculated LDL value may be erroneous. Why I am trying to say that most of the lab they do not measure LDL, okay. So, they calculate LDL through this triglyceride value. What you have to be mindful that when triglyceride value exceeds more than 200, 250, okay, then if you derive LDL from this high triglyceride value, that would be always erroneous. So, generally if lab reports point out that high triglyceride and low LDL value, then definitely if you look at this LDL value, if they say it is a direct method, if it is a measured value, then probably you can accept. But I strongly believe that most of the labs they measure the triglyceride through which only they calculate VLDL and LDL, of course. So, if triglyceride value is around 300, 350 or 250, whatever it is more than 200, then probably you specifically insist LDL be done through only measurement rather than the calculated value. So, in that way I do not think that this LDL value is a true value because the triglyceride value on the very higher side. So, whatever value they calculate for LDL which is derived from triglyceride must be a error one. So, if you look at lipid profile, the most important thing is LDL, because you are all aware that dyslipidemia worsen the status of diabetes heading for atherosclerotic cardiovascular disease. That is why it has been insisted that if anyone presents with LDL value more than 100, especially in a diabetes, that has to be focused and that has to be brought down diligently and aggressively. They say that normal LDL value may be 100, but if someone has diabetes and if their LDL value, if it is more than 100 also, to be taken very seriously, because this LDL definitely will promote atherosclerosis and pushing the patient for major cardiovascular event. So, any patient whose LDL value more than 100 in diabetic patient to be taken very seriously. But as compared to the western counterpart, most of the Indian population, they say South Asian population, they get all kind of cardiovascular event, namely MI and stroke, peripheral vascular disease at the earlier age as compared to western counterpart. So, the Lipid Association of India has drawn very stringent goals in such a way that if any diabetes patient, even irrespective of this LDL level, they say even the 70, they have made their cutoff value is somewhere around 70 for the diabetes. So, if their value is more than 70, then probably that patient should be put on statin. So, that is the big dictum of Lipid Association of India. Many our Indian studies reveal that when someone comes with the state of diabetes, do not look at LDL value at all. So, all the Indian diabetic patient, they deserve statin. So, that is the dictum what our Indian doctors are supposed to follow in view of high incidence of atherosclerotic cardiovascular disease at the earlier age. So, when you look at the lipid profile, here always you look at LDL rather than looking at the triglyceride. Probably the high triglyceride probably prompt you to go for a very aggressive therapy, and it will direct your mind to focus on triglyceride, but at any point of time you have to bring down LDL at any cost first. So, even though patient presents with high triglyceride, if someone is on LDL level more than 100 in diabetes, I do not want to take it, LDL would be the most important cutoff value, even though our Lipid Association of India insists, but I take it as cutoff value as 100. If any patient who presents with LDL more than 100, you start statin. First you bring down LDL rather than triglyceride, because the LDL reduction only alone leads to the life of free of atherosclerotic cardiovascular event. But generally triglyceride, they say if triglyceride more than 500, that hypertriglyceridemia leads to acute pancreatitis. So, generally if triglyceride level more than 500, why we treat that hypertriglyceridemia aggressively? Only meant for reduction of pancreatitis. When hypertriglyceridemia occurs somewhere around 1000, 2000, what happened? Their viscosity of the blood would be very high. Because of viscosity of the blood, so that what happened, that reduces the flow in the pancreatic ducts, leading to duct obstruction and ischemia of the pancreas, leading to the activation of pancreatic enzymes, resulting in acute pancreatitis. So, why we are supposed to treat hypertriglyceridemia is nothing but for the prevention of acute pancreatitis. So, when triglyceride level more than 500, treat hypertriglyceridemia for prevention of pancreatitis, not for prevention of cardiovascular event. If it is less than 500, if triglyceride less than 500, your focus should be on bringing down LDL rather than triglyceride. Someone presents with LDL level 111, if someone presents with LDL level 111, and triglyceride level 369, then you should not be biased with high triglyceride, because this triglyceride anything less than 500 is not going to produce any acute pancreatitis. Now, your entire focus should be on LDL that is present above 100. So, you have to start statin, but what you have to remember that statin based upon the dose, it can bring down your LDL up to 60%. But what you have to remember that even statin can bring down your triglyceride level by 30% at the maximum. So, when someone presents with increased LDL, for example above 100, but at the same time triglyceride level around 300, 400, start statin that can bring down your LDL, leading to reduction of atherosclerotic cardiovascular event, and parallelly it will bring down your triglyceride by 30%. That is the dictum. So, most of the time what happens in our day-to-day practice, when someone presents with the LDL 100 level and the triglyceride level 460, they address hypertriglyceridemia with the drugs which target triglyceride alone. They leave behind the LDL, then that is not a right approach. So, if anyone presents triglyceride level less than 500, you are little bit immune from getting pancreatitis. Now, your focus should be on prevention of cardiovascular event. That prevention of cardiovascular event is not bringing down your triglyceride level, you have to bring down your LDL, that is very, very important. So, in that way this patient triglyceride level 1289. Now, since triglyceride level is more than 500, this patient requires aggressive hypertriglyceridemia therapy for the sake of prevention of pancreatitis. But at the same time, you look at LDL also, but this patient, as I told you earlier, make sure that this LDL is a measured value or calculated value, because if it is a measured value, you repeat serum for the measurement of LDL. That is a direct measurement value should be considered. Now, this patient presents with triglyceride level more than 1000 milligram. Now, for the prevention of acute pancreatitis, now we have to treat triglyceride. So, how will you treat hypertriglyceridemia? So, basically, when someone presents with high triglyceride, basically the secondary causes to be explored. What are the secondary causes which lead to hypertriglyceridemia? One, poorly controlled diabetes. Many diabetic patient, newly detected diabetes patient, they used to present with fasting sugar 300, postprandial 450 milligram and a triglyceride level 460 milligram. So, these patient we used to, and the HDL level would be somewhere around 20. So, this is called typical diabetic dyslipidemia. They presents with high sugar and high triglyceride and low HDL. If you look at LDL, may be marginally elevated. So, why it happens? This is due to absolute insulin deficiency. When you have insulin deficiency, what happen? Your triglyceride level will be on the, your glucose level will be on the higher side. The most important thing is the insulin is the one that is responsible for the stimulation of lipoprotein lipase. What is the role of lipoprotein lipase in our body? Lipoprotein lipase hydrolyzes the triglyceride. It breaks down the triglyceride into fatty acid and glycerol. When you have insulin deficiency, what happens? The lipoprotein lipase is not activated, triglycerides are not hydrolyzed, so your hypertriglyceridemia occurs. This patient, if you administer insulin, that will correct your hyperglycemia. This administered insulin will stimulate your lipoprotein lipase, resulting in hydrolysis of triglyceride. Your hypertriglyceridemia will be reverted to almost normal value, even in the absence of any particular treatment directed towards hypertriglyceridemia. So, any patient who presents with the diabetic dyslipidemia in which hypertriglyceridemia would be prevalent, these patients deserve aggressive glycemic control which can lead to normal triglyceride level. That is very, very important. So, that is very, very important. So, any patient who presents with hypertriglyceridemia, explore secondary causes. If patient has hyperglycemia, treat hyperglycemia. Hypothyroidism, check thyroid function test. If they have hypothyroidism, correct or replace thyroid hormone, that can correct your triglyceride level. Then chronic kidney disease, they may harbor hypertriglyceridemia. Alcoholism can precipitate hypertriglyceridemia. So, I think that if they abandon the alcohol consumption, your hypertriglyceridemia can be reverted. So, any patient who presents with hypertriglyceridemia, think of secondary causes, always try to treat the secondary causes, then probably your hypertriglyceridemia may be reverted. But if triglyceride level would be very high level, then probably you should focus on the particular medication which will bring down your triglyceride level. So, the treatment of hypertriglyceridemia, one, find out the secondary causes, treat the secondary causes, and second one, the diet and weight reduction. It has been found that there are few components of diet can worsen your triglyceride level. Among this, most important would be the simple carbohydrate, I mean glucose. When you containing simple sugar containing drinks, for example, all kind of soft drinks, fruit juices. So, when you consume this simple carbohydrate, this glucose rapidly enters into your circulation. So, what happens? Our body is not in a position to handle this glucose. So, this glucose is taken back by liver, where glucose is converted into acetyl CoA. Very interestingly, when excess glucose is diverted to the liver, this liver diverts the acetyl-CoA that is derived from the glucose into a fat synthesis cycle. So, what I try to say, when you take simple carbohydrate or when you take excess carbohydrate, that excess carbohydrate will be metabolized to acetyl-CoA, then this acetyl-CoA will be converted into long chain fatty acid, something like palmitic acid, which is responsible for formation of more and more triglyceride. So, when you take refined carbohydrate and simple carbohydrate, then what happened, that will be converted into fat. That is very, very important. So, the most important dietary management of hypertriglyceridemia is ask the patient to drop the consumption of simple carbohydrate. Then another important is fructose. Why fructose is very particular about promoting hypertriglyceridemia and fatty liver is, as compared to glucose, if you look at the glucose metabolic pathway, there is some regulatory steps. They say, I think that if you recall your TCA cycle, there is one enzyme called phosphofructokinase is there. So, this is a very key limiting enzyme in the glucose pathway. So, when you take more and more glucose, what happened? This glucose metabolism will be stopped at particular point with the help of the negative feedback mechanism of this phosphofructokinase enzyme. When you take fructose, the fructose metabolism is not linked with this regulatory pathway. There is no negative feedback mechanism which can prevent the fructose metabolism. And another important, as compared to glucose and fructose is absolutely handled by the liver. That is why liver is the most important victim when you consume fructose. That is why we always, the fruit juices contain sucrose, which give rise to glucose and fructose. When you take fructose containing all kind of artificial drinks, this all lead to fatty liver. The reason would be the fructose is only handled by liver in our body, and the fructose metabolism is not handled by any regulatory pathways. Once fructose enters in our body, it is directly converted into acetyl-CoA, and that leads to fatty acid synthesis, then ultimately triglyceride formation. So, fatty liver is very, very common. That is why the most important part of dietary management in hypertriglyceridemia is ask the patient to switch over to more protein diet instead of taking carbohydrate. If at all if they take carbohydrate, then probably patient should take complex carbohydrate. I mean, instead of taking white rice which contains pure glucose, they should take the whole grain which contains glucose and fiber. So, fiber interferes with rapid glucose absorption. So, glucose is absorbed gradually, so our body is able to handle. So, hypertriglyceridemia, the most important dietary management would be avoid refined carbohydrate like white rice, and second one simple carbohydrate like glucose and containing juices and all kind of soft drinks, and third one the fructose, that is most important villain in promoting hypertriglyceridemia and fatty liver. Let them take more protein food, and if at all they take carbohydrate, more complex carbohydrate mixed with fiber, and second and the one they can take more amount of fat, but preferably something called healthy fat. We used to say monounsaturated fat and polyunsaturated fat, which are very prevalent in nuts and fishes. Better to avoid saturated fat like fried items and better to avoid all kind of vanaspati and dalda and so called ghee and butter. That is very, very important. So, this part the dietary management, and when they say when you have triglyceride level 1000 and 1500, probably the better option would be you bring down fat intake less than 15% of your total food intake. That is another important point. Then what are the drugs that are available for reducing the triglyceride level? So, before we get into the drugs that are available for hypertriglyceridemia, I would like to explain in a great way how this hypertriglyceridemia can be controlled with various drugs. Now, how hypertriglyceridemia occurs? So, let us see this diagram, then probably you will understand in a very better way. Okay. Generally, fat is available in two forms. One is triglyceride and cholesterol. So, this is main dietary forms of the fat. When we say I have consumed fat rich diet, means either the diet should contain either triglyceride or cholesterol generally. That is you have to remember. Okay. So, when you take diet, so in the diet you have two fat forms, one is TGL and second one is cholesterol. Okay. Very interestingly, when you consume a diet containing triglyceride and cholesterol, or either triglyceride alone or cholesterol alone, what happen? The cholesterol metabolism almost remains unchanged. When you take a diet containing cholesterol or triglyceride or whatever it is, the cholesterol will get into mouth and it will go down to small intestine. From the small intestine, it is simply absorbed into the circulation. That is one. On the other hand, triglyceride undergoes metabolism in such a way that this triglyceride will be handled by your salivary lipase and it is tackled by your gastric lipase and it is tackled by pancreatic lipase. So, the end product of TGL would be one, the fatty acid, and second one is glycerol. Okay. So, at the end of the day, when you take the diet, this triglyceride will be converted into fatty acid and glycerol. So, this fatty acid and glycerol should be absorbed by our intestine, but what happens, this fatty acid and glycerol cannot be transported as the same substance in the blood. So, what happens, this fatty acid and glycerol that are converted into the intestinal lumen will be absorbed by our enterocyte intestine and it will be again converted into TGL. So, when you consume a diet, the diet contains TGL, that TGL will be converted into fatty acid and glycerol in the lumen. This again these fatty acid and glycerols are absorbed, again it will be converted into TGL in the intestinal lumen cells. From the cell, TGL cannot be transported like TGL in the serum. It has to be carried by one carrier protein, that is called chylomicron. So, what you have to remember that the chylomicron is nothing but it one type of lipoprotein where your triglycerides and cholesterol and the outer covering you have apoprotein and phospholipid. So, through which this TGL is transported. So, what you have to remember that the triglyceride that are present in the food is converted into fatty acid and glycerol, but it is absorbed. But what you have to remember that again it will be converted into triglyceride in the intestinal wall itself. Then triglyceride cannot be converted as simply TGL. It should be packed well within one substance that is called chylomicron. This chylomicron will be received by our liver. Of course, chylomicron will be converted into various parts, that is a different story, but probably you may be confused. So, what I am trying to say, when you take more and more TGL, so I mean triglyceride containing food, this triglyceride containing food will be carried to the liver through chylomicrons. Then when triglycerides are excessively overwhelmed in the liver, this triglyceride should be exported out of the liver. Okay. Now, this triglyceride again cannot be travelled simply TGL in the serum. This triglyceride is now packed one carrier protein that is called VLDL. So, what is chylomicron? So, chylomicron is nothing but dietary triglyceride that is absorbed from the intestine is carried through the chylomicron to the liver. In the liver, once triglycerides are overwhelmed, then triglycerides should be expelled by the liver in the form of VLDL. That is very important. Now, this VLDL, okay, should be hydrolyzed, should be converted into this Now, the triglycerides that are present in the VLDL should be hydrolyzed. That is hydrolyzed by one enzyme that is called lipoprotein lipase. Okay. So, with this only the entire drugs clearly operate. So, what are the drugs that are available for bringing down your cholesterol? One is fibrate. Among the fibrate, we commonly use fenofibrate. Okay. So, the fenofibrates we are using in and out to bring down TGL. So, when triglyceride level is less than 500, okay, then probably we are using fenofibrate. Okay. But what you have to remember that the fenofibrate, even though it brings down triglyceride, okay, to a remarkable value, but the most of the long term studies like field study clearly fail to demonstrate that bringing down the triglyceride value with fenofibrate didn't get translated into reduction of cardiovascular event. What I am trying to say that when you administered fenofibrate to bring down triglyceride from 400 to 170, you may think the triglyceride level has come down. That means probably the cardiovascular event precipitated by this hypertriglyceridemia will come down. No, it does not come down. Now, the problem is we require a drug which brings down your triglyceride and as well as brings down your cardiovascular event also. That is why now they have introduced that is called icosapent ethyl. Okay, I think that many of are not aware of this drug. It is available as 1 gram. Okay. So, if you can initiate with 1 gram twice daily, okay, then you can step up the dose 2 gram twice daily. The advantage of the icosapent ethyl as compared to fenofibrate, both may bring down your triglyceride level, but through improved IT trial, the icosapent ethyl has proved that it can bring down your triglyceride and as well as it can bring down your cardiovascular event. As I told you earlier, when triglyceride level more than 500, then you are trying to treat hypertriglyceridemia to avoid the incidence of pancreatitis. But when triglyceride level is less than 500, you are trying to treat hypertriglyceridemia to prevent cardiovascular event, because once again I recall this point is very important. When triglyceride level is less than 500, the sole aim is to prevent cardiovascular event induced by hypertriglyceridemia. But before you treat hypertriglyceridemia induced cardiovascular event, when someone presents with triglyceride level less than 500, you should focus on LDL. So, you bring down LDL first with statin, which can bring down your triglyceride to some extent, then you just focus on hypertriglyceridemia. So, what I try to say that someone presents with LDL level, say LDL level 120, okay, then TGL level, okay, 278. Okay. Now, do not get attracted or do not get diverted or do not get biased with high triglyceride level as compared to LDL, because here we are treating TGL is, if anyone presents with TGL less than 500, why you are trying to treat it to bring down cardiovascular event, but bringing down LDL should be the sole aim to avoid cardiovascular event rather than bringing down your TGL. So, this patient deserves statin first to bring down LDL, which can bring down your TGL parallelly. Then, in the next visit after introduction of, okay, atorvastatin 10 milligram, okay, now your LDL level is 70, you are very happy, but triglyceride level is 211. Now the target value would be around 150, but TGL value is now it is somewhere around 211 because statin is able to reduce triglycerides too, that is why it has reduced. But from 211 to 150, you are making attempts to bring down only for prevention of cardiovascular event. But when you try to bring down TGL for the sake of cardiovascular event in this patient, you have to choose a drug which will bring down your TGL and your cardiovascular event. In that way, icosapent ethyl scores over the fenofibrate. Fenofibrate as compared to icosapent ethyl, fenofibrate is able to bring down TGL level around 50%. Okay, but the problem is that reduction of triglyceride by fenofibrate has not translated into the reduction of cardiovascular event. So the simple concept would be, when someone presents with triglyceride level less than 500, you should focus on first LDL, bring down LDL with the statin, which can bring down your triglyceride as well. Then after introduction of statin, repeat lipid profile after a month, but LDL has come down with the help of statin, but only moderate amount of TGL only has come down with the help of statin. Now still you want to reduce triglyceride level, then you have to choose icosapent ethyl rather than fenofibrate, because icosapent ethyl has proved that it is the one that is able to bring down TGL as well as cardiovascular event. That is very, very important. The only one the adverse effect of icosapent ethyl is when somebody is has a history of atrial fibrillation, then the studies reveal that there are some minor incidents of precipitating atrial fibrillation by icosapent ethyl. Then icosapent ethyl can precipitate bleeding those who are on antiplatelet and warfarin and newer oral anticoagulant. These are the two important mild adverse effect of icosapent ethyl. One is atrial fibrillation, and when someone has past history of atrial fibrillation, you should exercise caution, and when someone has has antiplatelet, then you should be very mindful. But when you think that cardiovascular event reduction is more important than any other thing, you introduce icosapent ethyl despite on antiplatelet, but you just watch the watch and monitor the episodes of bleeding. That should be explained to the patient. So here the take home message would be, first, when you find hypertriglyceridemia, don't be tempted to treat hypertriglyceridemia. Divide less than 500 and more than 500. More than 500, we are treating hypertriglyceridemia for the sake of prevention of pancreatitis, but less than 500 means then you have to reduce hypertriglyceridemia for the sake of prevention of cardiovascular event. But when you say prevention of cardiovascular event, you target LDL with statin, and still your triglyceride is on the higher side, you have two choices. One is fenofibrate and icosapent ethyl. Then icosapent ethyl has proved that it is capable of bringing down both your triglyceride level and as well as cardiovascular event. So whenever you find hypertriglyceridemia, this is the way you have to approach. In the next session, still the lipid metabolism will be taken in a very detailed manner. Thank you.